Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
So I'd like to review some of the data that has led to the approval of some of these newer agents. But before we launch into that, I'd like to start with another polling question. Which therapy do you believe holds the most promise for improving triple-negative breast cancer patient outcomes? Immunotherapy, PARP inhibitors, antibody-drug conjugates, some other targeted therapy, or you're unsure? Please vote. And we're going to review the data around many of these therapies that are now approved. And so let's see what you think is coming down the line. So it looks like a lot for immunotherapy, some antibody-drug conjugate votes, and then PARP inhibitors as well. And then some of you are a little unsure. So I think, again, this is an opinion question, but, I think there's something for everyone out there. So I'd like to start by reviewing two of the trials which led to the approval of PARP inhibitors for BRCA1 and 2 mutation carriers with metastatic disease. The Olympiad and Embraca trial were both randomized phase 3 trials, which randomized patients in a 2-to-1 fashion to the PARP inhibitor, either olaparib for Olympiad and talazoparib for Embraca, versus chemotherapy of physician's choice. Patients were eligible for these trials if they had HER2-negative metastatic breast cancer and a germline alteration, deleterious germline alteration in BRCA1 or 2. Some slight differences in terms of eligibility, in terms of the number of lines of therapy. So patients in Olympiad were a little bit more heavily pretreated. They could have had up to 2 prior lines of therapy. In the Embraca trial, patients could have had 1 line of therapy. And again, the very similar trials, very similar trial designs. The primary endpoint was to look at progression-free survival, with a number of secondary endpoints looking at overall survival as well. And in the lower graphs, you can see there the progression-free survival was statistically significantly better, favoring the PARP inhibitor in both of these trials. A 3-month improvement in the Olympiad trial for the PARP over chemotherapy, and a 4-month improvement in the Embraca trial. And so, the PARP inhibitors are generally associated with a significant improvement in PFS. These trials, neither one of these trials demonstrated a significant improvement in overall survival, but what they did demonstrate was a significant improvement in quality of life, favoring the PARP inhibitor. So not only is the PARP inhibitor more effective than chemotherapy, it's also associated with a more favorable quality of life. There was also a sense that the earlier the PARP inhibitor was incorporated in the metastatic journey, the more effective it was. So we really do want to make sure that we're testing patients for BRCA mutation status and incorporating PARP inhibitors early on in the management of metastatic triple-negative breast cancer. Looking at immunotherapy, the Keynote 355 trial is the trial that led to the approval of pembrolizumab plus chemotherapy for patients with advanced PD-L1 positive triple-negative breast cancer. This was a frontline metastatic trial. In this trial, patients who had metastatic triple-negative breast cancer who had not previously been exposed to chemotherapy in the metastatic setting were eligible. They could have had therapy for early stage disease, but needed to have a disease-free interval of at least 6 months. Patients were eligible regardless of their PD-L1 status, but they were stratified based on PD-L1 status. And then they were randomized to pembrolizumab plus chemotherapy of physician's choice versus placebo plus those same chemotherapy options. Chemotherapy here could be nab-paclitaxel, paclitaxel, or the carboplatin plus gemcitabine doublet. The primary endpoints, there were 2, to look at PFS and OS in the overall population in those who had a combined positive score of at least 10 and those who had a combined positive score of at least 1. And what you can see in the lower left-hand panel here is that those patients who had a combined positive score of at least 10 had a statistically significant improvement in median progression-free survival of about 4 months, favoring the addition of pembrolizumab to chemotherapy. And in the right-hand panel, this improvement in median PFS translated into a 7-month improvement in overall survival. So this has really solidified the role of pembrolizumab plus chemotherapy for patients with PD-L1 positive metastatic triple-negative breast cancer in the frontline setting. Again, here, PD-L1 positivity defined as a combined positive score of at least 10. The KeyLink trial was another trial which looked at pembrolizumab in the frontline metastatic triple-negative breast cancer setting. And in this trial, patients who had metastatic triple-negative breast cancer were treated with carboplatin plus gemcitabine and pembrolizumab. And then after this induction phase of chemotherapy, if they had a response or stable disease, were then randomized to maintenance therapy. So they were randomized to either olaparib plus pembrolizumab or just continuing what they received in the induction phase, carboplatin and gemcitabine plus pembrolizumab. And the idea here was to look at whether or not olaparib might be able to be switched out and offer patients an advantage over chemotherapy plus pembrolizumab. The primary endpoint here was to look at median PFS and OS in the overall intent to treat population. Patients were eligible for this trial regardless of their PD-L1 status, but they were stratified based on PD-L1 status and whether or not they carried a germline mutation in BRCA1 or 2. This was a negative trial. There was no significant improvement in PFS or overall survival favoring the maintenance phase of olaparib plus pembrolizumab versus chemotherapy plus pembrolizumab. So not a practice-changing trial, although biomarker work is ongoing in this study. Now, shifting gears to focus a bit on antibody-drug conjugates before I pass it off to Dr. Bardia. I think it's very important to think about how antibody-drug conjugates work. We know that antibody-drug conjugates are antibodies which are chemically linked to a drug payload. The antibodies target surface proteins on the surface of cancer cells. And so that antibody-drug conjugate goes and binds to the protein on the surface of the cancer cell. And when it does that, it becomes internalized into the cancer cell. And in the context of a lysosome, the toxic payload or the drug payload dissociates from the linker and leads to apoptosis of the tumor cell. Now, some of our next generation of antibody-drug conjugates have something called a bystander effect. And by that, I mean that toxic payload is stable outside of the tumor cell and can diffuse into neighboring cells, which may not even express the antigen that was being targeted and lead to apoptosis of those cells. And so that is what we refer to as a bystander effect. In addition, some antibody-drug conjugates can actually just release their toxic payload upon binding to the antigen and don't even need to be internalized for that to happen. So really exciting to think about this and how this has really changed and transformed the way we take care of patients with advanced cancers, breast cancer for sure, but a number of other malignancies as well. This bystander effect has really allowed us to expand our use of antibody-drug conjugates to tumors that may weakly or have low levels of expression of antigens that are tumor-specific. There are 2 antibody-drug conjugates which are approved, trastuzumab deruxtecan or TDXD, sacituzumab govitecan or SG, and then many others that are in development. 2 that are farther along in development are datopotamab deruxtecan or Dato-DXd, which is a TROP2 targeting ADC like SG, but with that deruxtecan payload like TDXD. And then patritumab deruxtecan, which is a HER3 targeting ADC, which has shown much promise in development and is moving forward into larger randomized trials. And so I think, this is just a handful of antibody-drug conjugates, but there are so many others that are in clinical development. The first ADC that was approved for advanced triple-negative breast cancer was SG, and it was approved based on the ASCENT randomized phase 3 trial. In this trial, over 500 patients with metastatic triple-negative breast cancer who'd had at least 2 prior lines of therapy for advanced stage disease were eligible. If patients had recurred within a year of their early stage therapy, that therapy counted as one of the 2 lines of therapy. And patients here were randomized to SG versus chemotherapy of physician's choice, just like we saw in the Olympiad and Embraca trials. And patients, the primary endpoint of this trial was to look at PFS, and secondary endpoints included looking at overall survival as well. And you can see here that the response rate was significantly higher with SG versus chemotherapy of physician's choice. And there was a 4-month improvement in median PFS, and this translated to a 5.5-month improvement in overall survival. So based on the ASCENT randomized phase 3 trial, SG was approved for patients who had received 2 prior lines of therapy, at least one of those lines of therapy in the metastatic setting, if they'd had an early recurrence after early stage disease. So really exciting data. Trials have been completed looking at SG in the frontline metastatic setting. And in fact, this agent has already moved up into the neoadjuvant and adjuvant space. So I have no doubt it will likely displace some of our therapies that we use in those settings. Now, shifting gears to think a little bit about HER2 targeting. We know that about 20 to 25% of breast cancers are HER2 positive. They have HER2 3+ by IHC or gene amplification on FISH testing. But there are a subset of tumors that have HER2 low expression. And up until a few years ago, we didn't really care about this. But now we have therapies which target HER2 low disease. And HER2 low disease refers to IHC of 1+ and 2+ on IHC staining. We know that about 2/3 of patients with hormone receptor positive disease have this trial enrolled patients with both hormone receptor positive as well as hormone receptor negative disease. In this trial, the majority of patients actually had hormone receptor positive disease. So 90% of the patients had hormone receptor positive disease, but 10% of the patients enrolled into this trial had hormone receptor negative disease. And so any patient with HER2 low disease was eligible. These patients had received 1 to 2 prior lines of therapy in the metastatic setting and were randomized to TDXD versus chemotherapy of physician's choice. You can see there were 5 different chemotherapy options here. The primary endpoint was to look at PFS in the hormone receptor positive population, but then secondary endpoints looked at PFS in all patients, overall survival in both hormone receptor positive as well as all patients, and then an exploratory analysis looking at those 10% of patients. So 58 patients in this trial had hormone receptor negative disease to look at PFS and OS in those populations. And what you can see in the panels in the bottom was that there was a numerical improvement in median PFS of almost a little over 5.5 months in the hormone receptor negative population, and a numerical improvement in overall survival of almost 10 months. And so these were not powered, obviously, to detect these differences with statistical significance, but these were in line with what was seen in the overall hormone receptor positive population as well as in the all-comer population. And so when TDXD was approved for HER2 low disease, it was approved encompassing the patients with hormone receptor negative disease as well. And so it's very important to think about testing patients for HER2 low disease to see if they're a candidate for TDXD. Now, this past year at FASCO, we also saw an improvement in ultra low disease, at least in those patients with hormone receptor positive disease. So I very well suspect in the future, we may not even be testing for HER2 by IHC. We may just be able to give patients this therapy. However, we need data in this space before that's likely to be practice changing. But I would like to briefly mention the DAISY trial. The DAISY trial was a small study that was conducted in Europe. It looked at 3 cohorts of patients based on their HER2 IHC expression levels. It looked at patients who had HER2 positive disease, so that was cohort 1. It looked at patients with HER2 low disease, so 1+ or 2+ by IHC. And then it looked at a third cohort of patients who had HER2 IHC of 0. And what you can see here is that the higher the expression of HER2, it seemed like the response rates were higher and the median progression-free survival was longer. But about a third of patients who had HER2 IHC 0 disease had a response to therapy and a median PFS of just over 4 months. Now, why is that? I will say that the antibodies that we currently use to test tumors for HER2 based on immunohistochemical analysis were primarily designed to detect high levels of HER2 expression. So their ability to discriminate between 2+, 1+, 0 is not that great. But it could also be that we really have a fair bit of tumor heterogeneity, and this agent has a profound bystander effect. Maybe you need very little HER2 expression to truly have efficacy here, or whether it's tumor heterogeneity, whether it's the antibodies not being so great, or whether it just really doesn't matter what the HER2 level is, and all patients will benefit from TDXD versus chemotherapy, I think remains to be seen. The other thing I'd like to mention, though, is that HER2 expression is not static. It can vary from one site of disease to another, and it can vary over time. And so this was a nice study in about 1,300 patients in China, where investigators studied patients who had metastatic recurrences. They looked at the primary breast tumor and the site of metastatic disease, and then they also looked at a second site of metastatic disease. And what you can see is that about a third of the time from the primary tumor to the metastatic disease recurrence, the HER2 expression had changed. And then about 1 in 6 times, it was different between different metastatic sites. And so I think it's very important to think about this. There was another study that suggests if you biopsy people enough times, you will get a HER2 low at some point. And I think they found that if you biopsy 5 different times, that you're very likely to have HER2 positivity in one of those biopsies. Now, I'm not advocating biopsying patients that many times. However, if you think a patient could potentially benefit, it's always worth, getting archival tissue, rechecking, or trying to get compassionate use of this agent. Now, datopotamab deruxtecan, another TROP2 targeting ADC like SG, but with a deruxtecan payload, so a different payload, albeit a payload of the same class. SG and TDXD and Dato-DXD all have topoisomerase 1 inhibitor payloads, but here was a phase 1 study looking at Dato-DXD in patients with advanced triple-negative breast cancer, and you can see from the waterfall plot here, really nice responses in these patients. About a third of patients had a response to therapy, and some of these responders had previously been exposed to SG. And so it kind of raises that question of how can we sequence agents, and can patients go on to benefit from another ADC, which may even target the same antigen or if patients have had, for example, TDXD. There's one patient here who'd had a deruxtecan containing ADC, also had, pretty close to a response to therapy with Dato-DXD. So I think there's a lot we don't know about how to sequence agents that target the same antigen with a different payload, or have the same payload and target different antigens. So a lot of work we need to do to sort that out moving forward. The Begonia trial was a platform trial in frontline metastatic triple-negative breast cancer. And in this trial, patients who had metastatic disease, regardless of PD-L1 status, were treated with either TDXD plus durvalumab or datopotamab deruxtecan plus durvalumab. And you can see that, again, these were small 30-patient cohorts, non-randomized data, but you can see pretty impressive response rates here with TDXD plus Durva in the frontline setting, a response rate of over 55%, and then Dato deruxtecan plus Durva, a response rate approaching 75%. So really exciting. These combination strategies are being tested in the randomized phase 3 setting. And what you can see in the panels below is that it doesn't seem that adding immunotherapy to these ADCs really seems to increase toxicity. They seem quite tolerable. And so I have no doubt these ADC immunotherapy combinations will very likely displace traditional chemotherapy, immunotherapy combinations. And those trials are ongoing now in PD-L1 positive disease, as well as in PD-L1 negative disease, looking to see if there may be synergy between the immunotherapy and a patient with metastatic TNBC should have their PD-L1 status assessed in their tumor, and they should have BRCA1 and 2 germline testing. There are a whole host of other things to think about as well, not included on this table: mismatch repair, microsatellite instability, tumor mutational burden, and TRK fusions. Areas where we have tumor type agnostic indications for targeted therapies, but those are a minority of patients with metastatic TNBC. But really assessing for PD-L1 and assessing for BRCA status. For patients who have PD-L1 positive disease and are BRCA wild type, chemotherapy plus pembrolizumab is an appropriate frontline. Give patients an opportunity to improve their overall survival. For those patients who have a BRCA1 or 2 mutation, who are PD-L1 negative, thinking about a PARP inhibitor sooner rather than later, because we know the earlier we give these agents, the more likely patients are to derive the most benefit. Unfortunately, if we have PD-L1 negative, BRCA1, 2 wild type patients, we're looking at traditional chemotherapy. And then for those patients who have both, are fortunate enough to have both PD-L1 positive disease and a BRCA mutation. Again, I generally start with chemoimmunotherapy because of the survival advantage, but then in that second line setting, we've got TDXD as an option as well, and that can be considered as well somewhere in sequence. And then beyond that, we're looking at traditional chemotherapy agents. But we know that SG and TDXD are both better than chemotherapy, and so incorporating those up earlier into the metastatic journey would be appropriate. And then a whole host of antibody-drug conjugates, which are in clinical development.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.